All righty, let's jump in here. Hi, everyone. Thank you so much for joining us today here at Anagram for a quick little run through on how to go out of network. We will dive into a demo. Want to remind everybody that if they have questions to go ahead and put them into the chat feature, and we'll be able to address them as we move through this. So just real quick, I'm Jenna Slater. I'm head of growth here at Anagram, formerly Patch. We are the same company, same mission to help patients understand, access, and pay for their health services by understanding their insurance benefits. I've been with the company since we first came to market in 2017, and it's been really exciting to see how we've grown over the years. Originally, putting the product in place to help people bridge the gap for plans they never wanted to accept, maybe some plans that don't have a lot of covered lives in the area and never made sense to be credentialed with. And now we are seeing a trend. Most people that inquire to get hooked up with Anagram are intentionally moving away from low paying vision plans that are way more headache than they're worth. So it's really critical to keep in mind that making the choice to go out of network and be what we like to call an open access provider requires strategic thinking. You are pivoting to a new business model, and there are a handful of elements outside of just implementing our software that you want to keep in mind before you officially pull the plug. You want to be prepared to think about marketing strategies. At the end of the day, using a vision plan is quick patient acquisition, but at a very steep price. And so if you're no longer going to be listed on their portal, you want to make sure you're either working with a marketing agency or you bring somebody in internally to get your presence out there via Google, Facebook, Yelp, all of the classic ways to acquire cash pay patients if you've never taken vision plans to begin with. You will have the enhanced freedom of being able to make special pricing offers and put referral incentives in place. All of those things are going to be much more available to you now that you're not following the marching orders of the vision plans. So on the flip side of having to be strategic and crafty with your marketing, you're going to be able to have so much more freedom in how you're running your practice. When filing claims through Anagram, you are not required to use specific labs. You don't have to have a certain amount of product on your frame boards. People can use their benefits toward anything on their shelves. A nice example is that if you're in network with VSP right now, patients actually can't use their vision benefits toward a Plano sunglass. So if you have patients with employer-sponsored insurance, but they don't have a prescription, they virtually can't use their coverage in your office. And when you're out of network, they can now apply that vision plan discount allowance to anything that they would like. So in a lot of ways, getting out of network doesn't just open up the door for freedom for you, but for your patients as well. And incorporating that into your scripts, taking the time to educate patients when they call in. If in previous years they were an in-network patient, for your staff to help explain to them the value and the benefits of why you have made this choice. Oftentimes we hear our customers touch on the fact that it really isn't, you get stuck between a rock and a hard place, and it really isn't a choice that you make willingly, but that you have to do it because you can't put the integrity of your healthcare and your practice on the line just to follow vision plan requirements. So making that into scripts are things that we cover in our training, but also a very important thing you want to keep in mind when making the transition. It's also important to know, right, that the value of each patient is going to go up exponentially. Not being held hostage to their fee schedules gives you the opportunity to set your rates so that patients are able to, pay for their services up front, and you're able to make more money per patient rather than having to chase down their accounts receivable the way you do when you file an in-network claim. So real brief, we've got different blog posts and editorials that we can send to help coach you through this process. But how you drop your vision plan is really important. Typically takes about 90 days for the plan to officially allow you off panel, you have to send in a letter of termination. You have to follow up with them to make sure they received the letter and that your countdown for the 90-day marker has actually begun. They then also don't typically notify you once you have officially been off the panel. So following up continuously after they've received the termination letter to ensure that you know when your drop date is super important. Dropping all plans at one time or taking care of them one by one is a personal choice. We have clients that have done both. Some like to do it all at once to rip the Band-Aid off and have the same process in their office for their staff to ensure there's no confusion. Others like to test drive. They'll maybe drop some plans that have a lower percentage of your covered lives so they can get their feet wet, get an understanding of how your demographic will respond to it, and use that opportunity to learn from previous patients and apply that as you then get off of other panels. Communication to your patients, which I just touched on too, is also super important. There's a mixed bag of opinions on whether you should send out communication in more of a mass email type of situation to notify them that their insurance is changing. We typically recommend having a personalized script so that when the patient calls in to book their yearly appointment, you know exactly how to explain to them our relationship has changed. We can still see you in our office. We can still apply your benefits at point of service. Let me explain to you how this is going to work. So taking that unique, really active sales approach is going to help ensure that the majority of your loyal patients stay and that new patients who are inquiring have this experience, you know, firsthand when calling to get to know your office. When we think about implementing new processes, there's always going to be a little bit of a learning curve. One of the things I love most about being out of network is that it's actually so much simpler on your staff than the in-network headache many people face when you're you know, dealing with modifiers, coordinating benefits, telling them they can't buy a certain frame because it's not within their scope of coverage. So the change is really the upfront conversation about what their vision plan really means, and it gives you the opportunity to frame it as a discount. We all on this call know that vision plans are just a discount. They are an allowance that get contributed to their annual visit and their materials. Patients that want only what their vision plan covers and don't want to spend anything out of pocket may not want to stay after you transition to this new business model, but the truth is those patients don't really bring in much revenue as it is. So it's about making sure that we're creating a practice where we're valuing the cost, or I should say the revenue each patient can attribute to our practice, and knowing we're not going to keep everybody, and that's okay. So now let's jump into Anagram so that you can see how our software flows. So what you're seeing right now on my screen is our out-of-network server. So what this means is this is where all of your soon-to-be out-of-network patients are going to live. So if you're going to be out of network with Davis and Spectera, all of those patients would live in here. If you're only out of network with BSP, you could consider this your out of network BSP portal. So if we have a returning member that's come in, you know, it's been a year since you've implemented our system, everybody is searchable by name and email so that we can quickly refresh their benefits. But when you get started on our system, it's going to be empty, a fresh slate, and we'll want to make sure that we get every member into the portal so that we're able to seamlessly file their claim and get them reimbursed when they make their way into the office. So first thing we do is add a new member into the system. There's two ways to go about that. One option that has become increasingly popular in the time of COVID, where you have really busy phone lines, you want to make sure that social distancing in the office is able to be applied. You have the ability to request their cell phone or their email and send the member information to the patient directly. They then put themselves into the system, so your staff doesn't even have to do that over the phone, and that data will then be owned by you and they will populate into the portal. Now, Most of our customers in a pre-COVID world did prefer the concierge approach, especially when they went from being in network to out of network, because it's what patients expect from their doctors. Whether it's reasonable or not is a whole different topic of conversation. But in this circumstance, patients are used to their doctors doing everything. So we enable them to have that same experience by first identifying who their insurance is with. Now, we are not I Dream of Genie. We wish we could be, but you can't search all of the insurance at once. Each of them have a different back-end algorithm, so we have to make sure that we know exactly who their carrier is with so that our system can do its job and find their accurate benefits. So the patient needs to know, do they have VSP? Do they have Cigna? Do they have Davis? We select the insurance from the list. In this circumstance, I'm going to go with the demo so we can role play and pretend this is VSP. And then we are going to need the primary member's information. So we automatically pull independents. If you have a wife and her kids in the office, but they're on their husband's plan, we'd need his information in order to pull in the entire family at one time. It can act as marketing generation at that point, because we'll then be able to show eligibility, not just for the person calling to make the appointment, but for the entire family, which is a huge plus here. So let's say, we've got Martin and he's called in and we need his first and last name, his date of birth, last four of his social, and his zip code. Now, same information for every patient, every plan, every time. Our system is sensitive to accuracy. So just like the in-network portals, if I happen to, misspell Martin's name by just accidentally adding in a letter, it's not going to find the patient. So we have to make sure that all of this is exactly as it's reflected in their insurance portal so that we're able to say, okay, great, let me connect to their plan and pull in their coverage. It will then put you into a queue where our system will take anywhere from 1 to 3 minutes to pull benefits. This is why we recommend collecting information at time of appointment booking. We've got a few different workflows our customers have implemented. You can either put them on hold and take them off hold once the benefits have populated, or you can tell them that you're going to call them back as you verify their eligibility. There's a few different ways that you can go about it, but the point here is this is really, really important, because if they went down the street and used their in-network or even their out-of-network benefits, let's say a week before, our system is going to tell you that. So you can think of this as your single source of truth. If they are not eligible for coverage, we're going to show the date at which it renews. If they don't have any benefits at all, we're also going to present that information. If they don't have any out-of-network benefits, which can happen, it's probably a plan administered through Medicare or Medicaid, and in that circumstance, it's probably just a discount plan in which they have really poor in-network benefits also. So it can still be a sales transition, a talking point to say, hey, looks like you don't have out-of-network coverage in our office today, but if you go in-network, you're going to have a selection of 4 frames and probably a low amount of benefit available to you. So let's find a way to, in a package deal, work something out with you today. So just because they don't have benefits doesn't mean that the sale is lost. But 9 times out of 10, they are going to have coverage, and our system is going to display exactly what they should be expecting from their insurance. So let's say, we're in a private practice and we're going to be doing services and materials. We work with optical only, where they're just administering product. We also work in a corporate OD setting if they're just doing services. But for the sake of the demo, we'll pretend that this is a private practice where we're going to be submitting both. We put in the cost of the doctor's fees. If we already have a cash-based time of service discount, we can apply that here. Most of our clients find that a 20 to 30% discount on top of what their reimbursement is will get them to a place where the patient is paying a comparable amount of money out of pocket as they would in network. So now you're able to see, as their provider, you're making $105 clean from this exchange. 45 of it will be covered by their insurance, and 60 of it will be covered by the member. So if we're talking about VSP, we have a feature called assignment of benefit, and that means that you as the provider can actually have the check come to you. So you're out of network, your relationship with the insurance is clean, use your own lab, administer your own product, but you can still receive payment from the insurance, and it will look something like this. So VSP will write you a physical paper check per claim that you sent in, will be written out to you, and this is what will allow you to accept the $60 at point of service, because we know that VSP is going to pay you the other 45. Now, if we're using Anagram for any of our other plans, IMED, Davis, Superior, Spectera, you are not going to be able to offer assignment of benefit. That is solely a feature for VSP at this time, meaning they're going to pay you the full 105 upfront, and the patient will ultimately be only spending $60 out of pocket, and you communicate to them. You communicate that to them via our print feature. We send out email confirmations. You can even, flip the iPad around. We have a lot of practices that have implemented kind of an Apple Store feel to be able to say, these are your allowances. You're paying us the full amount today. We're giving you a cash pay prompt discount, and you're going to receive a check from IMED in 3 to 4 weeks for $45. So really want to keep in mind here, when you operate as open access, it's all about communication. You really want to make sure that you stay in front of any objections they could be bringing up. You're spending the time to have a more active sales process on the front end so that the back end is clean. You get paid. You don't have to follow up with the insurance companies. You don't ever have to think about an audit or any of the other hoops that you jump through with your in-network contracts. So it's really just a shift of energy to be proactive rather than reactive, which the insurance companies haven't really given anybody any choice about. So to continue down this path of understanding how what we call our calculator works, we're going to put in everything the patient is ordering. So they've picked out frames for $300. They have picked out progressive lenses as well. Maybe we decide that we're not going to discount our services because $150 for an annual eye exam is absolutely reasonable. Maybe we're just going to administer a discount on the product side. So we'll come in here and put that 30% discount so that it gets applied to the total, where we're then again able to see you're making $570 from this exchange. Their insurance is going to cover $170, and the total out-of-pocket cost to the patient is $400. Now, the good news when you're making a decision about how you want to remove the presence of vision plans in your office is we've typically found that people take one of two paths. They either don't discount, they consider themselves a medically focused concierge practice, and they explain to their patients why their services are more expensive, and they expect to lose certain amounts of volume and make up for it in the higher value of each patient. Now, on the flip side, we have practices that either due to their demographic or the saturation of their market, maybe they're surrounded by a lot of in-network providers, they have decided to deeply discount and essentially match co-pays. So figuring out what type of a global discount we want to give across the entire exchange to get this net cost to the member down to what they would be paying if they were in network allows them to keep almost all of their patients, if not all of them, but maintain that same value per patient. So you may not be making any additional revenue per exchange, but you don't have to worry about losing the volume. Something that we've heard in, passing in anecdotal evidence is the first year that I dropped the plan, I felt a dip in volume. Typically anywhere from 15 to 20% of patients on that plan will be what we call insurance chasers and will look for somewhere else to go that accepts their plan. But what they've found is that after the first year, they actually get those patients back because they do value who their doctor is. They want to work with providers that care about them. And if you've created that relationship and built a really great process with your staff in the office, we have found and make the joke here at Anagram that they always come back, because they'll start to realize that staying loyal to their vision plan doesn't benefit them the same way that staying loyal to their doctor does. So at this point, this is where we spend the majority of our time in Anagram, having the dialogue with the patient, explaining to them what their coverage will be. And then the last step that we take here is filing the claim. So we electronically submit these claims. You won't have to ever ask your patient to deal with an itemized receipt or a CMS 1500. On average right now, people that ask their patients to self-submit out-of-network claims, and granted this isn't just in vision care, but across all of medical, they have about a 26% acceptance rate, meaning the majority of claims are rejected, not denied, but rejected because they just weren't properly filled out. A lot of potential for human error when submitting these things. So by using our system to get these claims sent through is going to ensure that we are eliminating that potential of rejection and getting either you as the doctor with AOB paid out or your patients paid out on the first try. Our system auto-populates CPT codes, the most popular ones used through our system, but anything that you could potentially be billing for is available in our system. So if we want to use the 92004 instead of 002, that's offered here for us. Maybe we've got a staff member who's new to billing and they don't know anything about CPT codes. If they pick out a code that's actually not reimbursable and is not going to get paid out, our system is going to stop them. It's going to give them a note saying, hey, it appears you don't have the ability to be reimbursed for this code, so let's try this again. A little bit of a fail-safe process to ensure that we're doing everything we can on the front end to remove potential of rejection. Same deal with the diagnosis, really easy, type in, scroll down, mimicking Google a bit. We can either find the diagnosis and the CPT code by typing in the code or by typing in the actual diagnosis. So we'll pick it from the list. Again, these are just our most commonly used codes, but maybe the patient purchased sunglasses. We type it in, we pick it out. This is how we're going to ensure that the vision plans don't have access to your data anymore. You don't have to clarify what kind of frame this is. They don't need to know what type of progressive lens you're dispensing. This is completely up to you autonomously as the provider, but this way you're going to be able to see, okay, great, I'm submitting for a code that will in fact get paid out. Now, to complete the claim, we need to put in the total amount of money spent by the member. So if it's IMED, they're going to pay us the full $570 upfront, $170 going to the patient. If it's VSP accepting assignment, we'll put in that $400 to keep our bookkeeping clean and know that we're expecting a $170 payment back. Then the last bit that we need is their mailing address to ensure that everything matches the insurance company's records and that patients are going to get paid. You know, unlike the insurance companies, we're never going to direct market to your patients. We don't outreach or connect to them at all. No more having to worry about somebody intercepting your patient by ushering them to buy glasses online at a 20% discount. All of those problematic, you know, areas of communication that we see happening with vision plans completely go away when you are out of network, so you have more control over the conversation. Now that the claim looks complete, we click submit, and we bring the experience full circle by sending them a confirmation email. And so, you know, it's really critical to keep in mind what you're doing when you pivot to out of network is putting a new business model in place. And if you have a good patient experience, they will stay. You know, if you build it, they will come. It really is true. People value convenience. They don't know how their vision plan works. If you have the opportunity to educate them and make it easy on them, let them know, hey, your claim has been filed, money is on your way, and if you have questions, they're redirected to us here at Anagram. So a huge benefit to working with us is you can think of our team as the muscle between you and your patients and their insurance. So if a claim needs follow-up, All we have to do is touch base with our in-app support. These are real people, not robots. They answer questions in real time. We would simply go into the claim and pull their claim number. We need an update of claim status. For Martin, we start the message, we send this to the team, status update, please, and we take it from there. So you don't have to worry about your staff spending hours on hold with Davis finding out the status of a payment. We do that for you, and that's all included in our service. So to bring this full circle, our dashboard here is built into the app so that you have the opportunity to see how much money you're making with Anagram, how much is each patient worth in your practice, what is the total revenue billed through our system, and what is your conversion rate? How many patients are staying versus how many claim or how many patients have been added into the program. So that will let us know, is there room for improvement? Maybe you have multiple locations and one location is just absolutely blowing it out of the water and another location needs help. This gives us and our customer success team who gets dedicated to your office the opportunity to dig in and figure out what practices we can put in place to help improve. So I know that we only have a few minutes left, but I want to make sure that we get any questions answered that may have come up. So to learn more, you can always email us directly if you want a personalized demo for your office to talk about your use case, because not every practice is alike and we want to be able to talk through your pricing and your demographic. Please reach out and we can absolutely do that. But for now, if anybody has any questions, please feel free to enter them into the chat and I'll answer as best I can. Okay. Is Anagram looking at bringing on more insurance? It seems like it's been the same since we started using it a few years ago. Great question. Um, we're looking into it. The truth is the other plans that we could build integrations for, like Avisis, Humana, NVA, they don't really have out-of-network coverage. So building an integration with them wouldn't make sense because every time those patients would get pulled up and say no benefits available. But as new vision plans emerge, if they offer out-of-network, we'll absolutely work to build out that functionality. Oh, Marty, about estimated cost. So we are a subscription-based model. We cost $200 a month on an annual agreement for unlimited use. So add as many patients as you need, file as many claims as you need for that $200 subscription. Thanks, guys. Appreciate the engagement and everybody taking time out of their busy workday to attend the call. Again, if you have specific questions for your practice, please reach out. We would love to dive in a bit deeper. All righty, and at that, I will stop sharing my screen. And again, thank you everyone for your time and I hope you have a great rest of your day. Cheers.